Hi everyone, I'm going live today, right now, with Orthosmiles. I hope you stay on and join me. Hi guys, thanks for joining me. I am going to connect in with Orthosmiles. And they're going to be joining me now in a moment. Hello.
Hello, can you see us?
I can see you. Is
So
Stacey
are you?
or what? Let me see.
Flip it to me.
Oh, I can hear you, Stacey.
Hi, how are you? Can you see me now?
I can.
We're socially distanced in the office.
Ever. I'm going to pin a little topic at the top so people know what we're talking about today.
Perfect.
If you guys want to introduce yourself, so anyone who just tuned in, this is Dr. Aisling Whitaker from Bitehaus. Today is not about me. I am joined by Dr. Brian Lasky, Dr. Stacey Kirschenblatt from Orthosmiles. They are one of my main referral clinics for orthodontics. I'm so delighted to have them on with me today. And they are local, so support local. They're right down the street on St Clair. And I'll just give them an opportunity to introduce themselves.
Yes, Dr. Whitaker, thank you so much for having us. We're excited to be with you on this beautiful day. And we're so happy to be back in the office. It's been a while, but this is helping to get us excited about returning to work soon. We absolutely love the area. We've been here on St Clair Ave West for the past 4 years. Doesn't feel like 4 years. Time flies, and we love working down the street from you and working with your patients.
And Stacey, are you there? I don't know how you guys are doing this. This is exceptional.
Hello, hi, I'm Dr. Stacey Kirschenblatt, and we're very excited to be back in the office, and we're hoping, I'm sure you are too, to see patients hopefully soon. We're waiting for a word from, the government and our college to say, let's go, because we are ready to go, and we are excited to get back and help our patients and help new patients straighten their teeth, fix their bites, create beautiful smiles. So thanks for having us today.
My pleasure. So over the last week or so, we've received a number of questions from people tuning in and from various parents that come to Bitehaus. And everybody feel free to ask in the comments any questions. We're happy to keep this very casual and ask any questions as they come up. So please feel free to ask away. So to start us off, let's talk a little bit about when is the right age for somebody to be referred in, or for a child, for example, to come in for their first orthodontic assessment?
So it's recommended by the Canadian Association of Orthodontists that children be screened by age 7 or 8. And that's really beneficial for several reasons. There are a few features of a child's bite or eruption of teeth that's really important to assess and intervene. And so if we see a few certain things that we are curious about, then we may want to intervene at that age. But the majority of kids don't need intervention at that age. It's to make sure that we don't miss something and don't miss the ideal window for treatment. But the majority of patients, we see them and we are happy to follow them as a courtesy, for several years until they're actually ready for orthodontic treatment.
And when the dentist is sending them in for that first assessment at 7 or 8, what would you like from us? Is it a panoramic x-ray? What kind of history would you like?
Yes, panoramic x-ray is very helpful. We have the ability to take one, but oftentimes we don't want to take another one if one's already been taken at your office. So
Sure.
We love to share the x-rays. And there are some situations where the x-ray is covered by insurance in your office and not ours. That does happen. And so, when patients come to us for initial consultation and they already have a Panorax, that just makes things easier. We'll often look at it, before the patient comes in. So it's very helpful.
And like from my point of view, one of the things I'm looking for at that point, and I'm sure this is what you're alluding to, is canine position. So that's the eye teeth here on the side, the pointed teeth, whether or not they're coming in a good straight kind of position, or if they're getting stuck or what we call impacted against other teeth. That's something that you definitely want to address early and not wait until they're 12 or in their teenage years. Is that right?
Yeah. Impacted teeth is one of the things that we look for, and we're trying to assess when we see them at 7 or 8, what's the tendency, what are the chances that the canines may be impacted. And from the research, from the literature, there's certain features that may give us an indication that a child may be prone to impaction. But we're also looking at the eruption of teeth, are teeth coming in at the right age? And if they haven't come in, why haven't they come in, and what can we do to help them come in? Other things that we look at are cross bites. So if teeth are not, upper and lower teeth are not in the correct relationship to each other, that's very important to address, early when we see it. You want to add anything, Dr. Stacy?
Yes, no. So x-rays are wonderful to get before the consultation, but for patients that don't have x-rays, come on in and we'll still do an assessment. And like Dr. Lasky said, I'd say the majority of our patients that come in at age 7 or 8, we end up monitoring free of charge every 6 to 12 months, just to make sure that we start treatment at the most appropriate time. Our goal is to get children in and out of braces as fast as possible, and so timing it at the right time is the most important. So we never want to start too early, and we also don't want to start too late, like in situations like impacted canines. That's something you don't want to wait until you're 15 years old and wondering where those adult teeth are. So,
are they missing, or
Exactly. Oftentimes, your office is wonderful. We love working with you because we know that you're keeping track of your patients, but there are times where we see patients seeing their dentist and they think everything is going according to plan and no x-ray was ever taken. So although it may seem daunting or really young to take an x-ray at age 7, the x-rays that we use and your office uses are digital and the radiation is quite low. And without having those x-rays, we're blindly assessing and diagnosing your child. And so it's very important for us to have those images so we can give you the appropriate treatment.
And that's age as well. They're 7, they've got their first adult molars in, along with many other adult teeth. Those first adult molars for us, they're the most vulnerable for your whole lifetime to get a cavity in. If anyone out there just has a couple of cavities, I can almost guarantee you they're on those first molars, because they're in your mouth from the age of 5.5 till 95.5. So it's a good key age to get that standard x-ray for cavities and also that orthodontic x-ray.
Exactly.
So is there any cases, very specific types of bites that come together that really benefit from early braces? So I know traditionally people think of braces as traditional train tracks, and they think of them 12, 13, or even later when all of the adult teeth are in, let's say. But are there some certain cases that you like to start treatment on early, and what type of treatment would that be?
Sure. So first, when we talked about cross bites or upper and lower teeth not in the correct relationship to each other, often that's due to crowding. And there are things that we can do at a young age to make room for adult teeth to come in, and that can help make things easier down the road. So crowding and related to cross bites or the relationship of the upper and lower teeth, that's something that we like to address very early, and we'll get back to that in a moment. When we also talk about like the jaw relationship, there's different jaw relationships, and if a child has a prominent lower jaw, that may result in a total underbite. So we're not just talking about one upper tooth to one lower tooth, but the entire lower jaw or all the lower teeth are in front of the upper teeth. The literature shows very clearly that kids can benefit, and actually we can do more for those kids between ages 7 and 10. Certain modes of treatment after age 10 do not work as effectively.
Growth spurt time, right? So if you start to see your kids where their trousers are getting short every 5 minutes and their shoe size just can't keep up with those that's a great time to get in there and take advantage.
Yes, so underbites and prominent lower jaws are probably the hardest cases that we treat. And yes, you're right. They continue to grow. Once they're to the growth spurt, we're almost playing catch up. The lower jaw is one of the last bones in the body to stop growing. The mandible can grow until age 20 or 21. So the reason we want to start early is we actually want to overcorrect. We want to give them room in their bite to grow into their bite. Unfortunately, if this is missed, a lot of these patients need jaw surgery when they're older. And so if we can do anything to avoid jaw surgery, that's amazing. And we have been able to, when we're able to intercept these bites.
Yeah, because that jaw surgery as an adult leads to quite significant downtime.
Yes. And it's amazing what they can do with jaw surgery, but it's not a fun procedure. So it can be avoided. Ideal. Yeah. Going back, and I'm going to pass over to Dr. Kirschenblatt in 1 second, Dr. Stacey, our philosophy in treatment, making room, addressing crowding at an early age stems from our backgrounds of practice and education. First of all, we both grew up, with having mentors. My father was an orthodontist. Dr. Stacey's uncle is an orthodontist.
My dad.
So really? So I'm sure that's shaped the way you practice. A lot of the way we practice and the way we like to do our treatment is based on what we've seen for many, many years. And so one of the features of our practice that we're very proud of is that we almost never extract teeth. It's very rare to extract permanent teeth, often the bicuspids or premolars were extracted. That used to be the tendency in the profession. It is less now, but it is still used as a treatment modality. We have 2 locations. In addition to being on St Clair Ave West, we have a downtown location, and we see more problems in adults that had teeth pulled than those that didn't. So again, that shapes us. If we can help someone at an early age to avoid needing teeth pulled, that's really beneficial, and that's why we recommend that, and believe seeing them at such a young age, just to help intercept those few patients that could benefit from it.
Yeah, and to add to that, part of the reason why we like to see kids young is because not only do we do orthodontics, but we're actually doing orthopedics. We're actually changing jaw structures when we expand and use spacers or expanders to try and change the jaw structure, and that can only be done while children are young and growing. So once you get to the point where you're past that growth spurt, oftentimes the only way to resolve crowding or bite discrepancy is with extracting teeth. So it's really important. We love when you send us patients young and for parents to get their children in so that we can make that determination if orthopedics needs to be done in addition or before we even talk about straightening teeth.
And when I get, I get the full family. So I see the kids and I see the parents, and the parents I say to the parents, did you or your partner need braces? And they say, oh yeah, I was in braces for years. I had tons of teeth taken out, and I have this lower anterior crowding, and like I still have. I'll probably have to come and see you guys. And they remember that journey, and they remember that previous philosophy that we waited, or some orthodontist philosophy that we waited and we extracted and things like that. If we can keep everything, we're also interested in keeping enough space for the tongue, reducing issues like airway issues and things like that at a later stage. So that's why you guys are trying to expand and make more space. Is that right?
Yes, exactly right. Exactly right. So one of the biggest determinations of are your teeth going to be straight, are they going to be crowded, is genetics. So having a family history, we hear, my dad had jaw surgery when he was 18 years old. Okay, well now it pops into our head, well maybe this is something that we should look into to make sure that your child maybe is treated sooner so that they don't need to have jaw surgery. Or it's maybe something that we say, okay, look, maybe you might need jaw surgery in the future. So genetics is a huge component. So knowing if a parent had teeth pulled out when they were younger, well, maybe using expanders and other orthopedic means to create space may be a little bit more important. You mentioned airway, and airway is a huge concern that we have nowadays. We're seeing more and more adults and children being diagnosed with sleep apnea. Snoring and breathing issues in children, it's dangerous, and it can lead to attention deficit disorders. It can lead to malnutrition, weight loss, all sorts of problems in kids. And so there has been a lot of research and studies done that show that orthopedics and expanding the upper jaw, opening the airway, creating more room in the nasal passage to help children breathe through the nose is super important. Mouth breathing in children is not normal. And I think it's really important for adults and parents to be aware that your children should be breathing through their nose. There can be several reasons why they're not. It could be a deviated septum, it could be adenoids, it could be a whole slew of things, and not necessarily the jaw structure. But we are finding that a lot of kids have really narrow upper arches, and that widening them can help with their breathing and help with their sleeping.
And along with that, would thumb sucking and things like that be an issue in terms of that?
Yes, because the habit of thumb sucking does not help the arches, and thumb sucking is something that we actually find that we're having to discuss it and address it more and more. I'm sure there's a lot of stress, especially right now, and some kids use that as a coping mechanism. And it's normal. I'm a father of 3 daughters, all who are thumb suckers. When we're in,
we're not.
We're taught in school that we have to eliminate it by age 2 or 3, and then when you're a parent, you realize that's not so easy. But we do try to help kids eliminate the habit as soon as possible, and we do that a lot more with coaching. While we can't put something in the mouth to help, that is our last resort. I would say that we only have to put a habit breaker maybe once or twice a year. And we see 20 to 30 times the patients with thumb sucking, but coaching them, giving them some tips on how to stop on their own. And we do show them what we can put in. It's a little bit of a incentive to show them, like, if you can stop on your own, this will be easier for everyone involved. But yes.
How does that arch expansion work? So parents may not be aware about the fact that our bones in our face fuse together. There is a kind of like if you think about the world and the way that the lines on the earth came together, there are these little craze lines that have the potential to be expanded.
Yes, we actually have one of our presentation slides up here, so I'm going to flip it around so you can see. Can you see the screen okay?
Yes.
Okay, perfect. So right now, this is looking at sort of from the bottom.
The roof of the mouth?
The roof of the mouth. And this is what one example of an expander looks like. This is our preferred design. So first, the maxilla, which is the technical name for the upper jaw, is actually 2 bones, the left and the right side. And they don't fuse together until roughly age 15, 16. They fuse a little bit earlier in females than males. And so using the expander, which we teach parents how to turn this appliance with a special key. Usually they turn it once a day. It expands the maxilla like this, and that gives room to straighten the teeth or creates room to allow teeth to come in. So this is very safe to do before age 15, 16. And in fact, the younger you do it, the easier it is for the patients. We don't, some pediatric dentists will do it even younger, and that's great. We're actually supportive of that. But in our practice, we're set up, we want to do it for patients when the patients are also understanding of why we're doing it. It's not something we're forcing into their mouth. And so we won't do it until the patient's both skeletally ready for it, but also, mentally prepared and are going to cooperate, with us. But it's very easy to do this. It's very safe to do it. And it only has benefits.
And well tolerated.
And well tolerated, yes.
So there's obviously kind of an ideal width that you want those 2 molars on the roof of your mouth to be far apart from each other.
Yes, a lot of times we use the lower arch to help guide us to see how wide the upper arch should be. There's definitely, you don't want to expand too far. You also don't want to do too little. So we know a lot of times once the bone refuses, we get a little bit of relapse, so we tend to always overcorrect. We tend to see these patients most frequently in our office. So you come in every about 2 weeks, so that we're just assessing how the turns are being done. The parents are doing the turning at home every night, so we're not the ones turning it every night, so it's very important for frequent, quick checks just to make sure we're getting the right amount of expansion, not too much, not too little. That's kind of like Goldilocks. There's the perfect balance.
Sorry, can you repeat the question?
Painful?
No.
Oh, sorry.
Is it painful?
Oh, is it painful? No, so most of our patients say most say they feel nothing. If anything, they may feel a little bit of pressure while the turn is happening, and about 2 minutes later, it sort of goes away. Amazing. We recommend doing it at night before bed so that the kids go to sleep and they sort of forget about it. Some patients sometimes feel a little bit of tingling in their nose because the roof of the mouth is the floor of the nose, so it is helping with the nasal airway. But other than that, no, we don't hear complaints about pain at all. If anything, just speech is a little bit affected, and a lot of patients say they have more saliva. We always joke that your brain thinks it's food in your mouth, so it's sort of you're salivating a bit more in the beginning with it, and then you get used to it.
Makes sense. Makes sense.
And kids are so resilient; they adapt to this appliance literally within a few days, and so much so that by the end, when we're done, and this treatment takes roughly 8 to 12 months. By the time we remove it, they feel weird without the appliance.
They got used to it.
Yeah. The key, with all orthodontic appliances is hygiene and also appliance care. And so we really, as we're leading up to this treatment, we tell kids to enjoy certain foods that they really should not have with orthodontic treatment. We really want the patients to avoid hard, sticky foods. Because if this appliance breaks or becomes loose, we can lose about a month's worth of work in 24 hours. So again, to do it properly and do it once, we want the full cooperation of the patient.
Ideally, that is after they have their first molars, somewhere around the age of 8 or something like that.
Yes, usually 7.5 is the earliest. 7.5, 8, 8.5. We want the first molars to be in, but we also want the first molars roots to have developed, sufficiently to withstand the pressure. So again, sometimes girls, female patients are ready for the appliance a little bit earlier than the males. But it's not something we're rushing to do. When they've come to see us by age 7, it's amazing because we know we have them at the right time, and oftentimes they're even in to see us a little bit early, and we can plan it. We want to plan this around family travel plans and functions, summer camp. This is not something that we will put in right before a vacation. If a patient's not tolerating well, we don't want it to ruin their vacation. We want them to be around for the first month when we're doing this so that we can be here to help them.
And you touched on something which I think is a nice segue in terms of hygiene being very important. And I think one of the questions that we got was, about children who are in braces and they're really struggling to keep things clean. Obviously, once you do get to the stage where you have full braces in your mouth, traditionally called train tracks, be it either the silver type of looking ones or the porcelain type of looking ones, the white ones, a lot of children find them pretty hard to keep clean. So what kind of cleaning protocols do you recommend for those people who are in braces, and any favorite little tips or products?
Yes, that's something that's really important, because it's one thing to give people a nice, beautiful smile with straight teeth, but if the teeth haven't fared well because of hygiene, it can be heartbreaking. And so we're on this at every appointment. We like to let our patients, when we're doing the orthodontic adjustment, brush their teeth when we may have taken out, a wire or elastics. Unfortunately, because of COVID restrictions, our brushing stations will be closed for the next little while. But that won't stop us from, helping patients to, practice good oral hygiene. So we provide all patients with a hygiene kit when they start orthodontic treatment, everything from a travel brush to little picks, proxa brushes that they can go in between the braces and the wires. Basically, we tell the patients they have to approach the brace from every angle because food can get stuck, under all the little nooks and crannies. What we find most is that kids miss the gum line, and brushing at the gum line can be sensitive. If plaque and food builds up, the gums can start to bleed. So we have to teach them proper brushing technique and, reassure them that, yes, if they've had some difficulty, if they practice the good oral hygiene for a week, the gums will improve, the inflammation will go down, the bleeding will subside. We really like to recommend a water pick, which is a heavy stream of water. It's really good for getting stuff around the braces and also at the gum line.
And one thing that I've noticed is children who are finding it difficult to brush, the gums kind of start to grow down towards the braces. So is there anything that they can do at that point?
Yes, so flossing, super, super important to help with the gums. Gingival inflammation is a big problem, and it's usually due to the fact that the plaque is sitting there right underneath the gums, right by the gum line. And so you really need to get that plaque off. So like Dr. Lasky said, a water pick is great to help. Flossing is difficult with braces. We acknowledge that. It's not easy. It's not easy at the best of times, even without braces on, to floss. There are certain little instruments that we give, floss threaders. There is floss that has a little plastic on the end of it to help floss. There are little platypus things, all sorts of tricks that we can go over with patients. And then also seeing your office more frequently. So typically we're used to going to have cleanings done every 6 to 9 months. A lot of braces patients, we recommend going every 4 to 6 or even 3 to 6 months and have more frequent cleanings at your dental office, because a professional cleaning really gets in there and does a good job, better than you can do at home.
Yeah, and I noticed that, once the braces come off, if the gums have grown down, after a number of months of more vigorous brushing, they will shrink back a little bit.
For sure. We never tell people, we never get too alarmed. I mean, sometimes we do. Worst case scenario, we can sometimes take off the braces if it's really bad and the child's really negligent with their brushing. But like you said, most often once the braces are removed and the source of irritation is taken away, the gums shrink back. Once you get into normal brushing, normal flossing, rinsing, they do resolve.
One of the concerns that we have when we see them is if you get little bits of plaque around the little square bracket and you leave it there, it can leave that little white square on your tooth surface. So is there any products that you recommend that can help with that?
So that's the biggest problem. I mean, what we don't want to happen is you end up with straight, beautiful teeth and we go to remove your braces and you almost have like a white, you'll see in certain people, they have like a white square, a white box exactly around where the braces were. We call them white spot lesions. They're areas of decalcification. So the enamel has been demineralized where the acid has been sitting, the bacteria has been eating away and creating a cavity. They are permanent marks. They are very difficult to get rid of. So we try and nip it in the bud before it even gets to that point. But if it does happen, there are new toothpastes available. MI paste, it uses a cheese casein protein that helps remineralize the tooth surface. It's not perfect. It does help a little bit. We have seen some success, but we try and really nip it in the bud because the only other alternative if these white spot lesions are really bad is doing a filling or a veneer or something when the children are older. So we don't want that to happen. So every time our patients come in for their appointments, they do get graded on their oral hygiene. We have an oral hygiene rewards program here. So if you come into our office and you have straight, beautiful, like clean, healthy teeth, your gums look healthy, you don't have any plaque buildup, you get a ballot to enter in to win prizes. We give away Leafs jerseys, concert tickets, gift certificates, all sorts of prizes to help incentivize kids to keep their teeth clean, because we know the last thing we want to happen is have these cavities on the front surfaces of your teeth because they're not very pretty, and it's a disappointment when that happens.
Yeah, and it's something that they may not expect. They may not when they take it off.
No, for sure. It's something we go over at the beginning of every new start case. We show pictures of exactly what it looks like. I mean, part of it is a scare tactic, and part of it is we want them to be aware that if you don't do this, it's likely that you're going to run into trouble with this. And anytime that we're starting to notice it, parents are called in, there's a consultation to go over, this is what we're starting to see, so that we can nip it in the bud. One thing that is a huge contributor is pop, soda, anything like that, sugary drinks, really acidic drinks with braces, terrible for your teeth. I mean, terrible at the best of times, and then you add the braces on, bad brushing, more difficult to floss, and we're seeing a lot more decalcification with sugary drinks like soda.
That MI Paste product it's a really cool product, and it's so popular in certain countries. Australia used very widespread, and I found that not a lot of my patients in Canada were aware of it. You guys have it, and we also have it at Bitehaus. And we can even make trays to fit over your braces, so that you can put this foam into your into clear trays and wear them over your braces for a number of minutes to help really try and infuse the enamel surface back with some of the minerals that it's lost. This is for
like a bleaching tray, but with like a remineralizing toothpaste.
Exactly, and you can get it with or without fluoride if parents are concerned about that. And it's just full of consider it like a multivitamin for your teeth. For
sure, exactly.
And I think
well, actually.
Sorry?
We've found good results with it for sensitivity as well.
Yes, for sure. And I think the most important thing is that we're working together as a team, because if the patients that are having challenges with their oral hygiene, the more they're hearing the same message, the more that it sinks in. Yeah. And so it's really helpful, when we are, recommending to patients certain things, but also when our staff is saying the same message. Sometimes it just takes some time and hearing it from a few different people before the message gets through.
It's also delicious because it comes in lots of
Yes.
Tutti frutti, vanilla.
Melon, I think, is one of them.
Yeah, melon. Yeah, it's I don't know why, but they have a lot more flavors than regular toothpaste.
I know. So you touched on a little bit, how often should my child visit the dentist when they have braces on?
I mean, a lot of that comes down to how well is the brushing going on. And so typically, I think you see patients every 6 to 9 months.
So, this is one thing that often parents are a little bit confused or concerned about based on their insurance. So ideally, I'd like to see them every 6 months, children. Obviously risk dependent on a number of different things. Sometimes patients' insurance covers them every 9 months. That can be an issue. But, from a health perspective, I think so much is changing in children's mouths that I think 6 months really plays into a nice prevention strategy. However, when they're in braces, I really like to see them, every 4 months, just even for a quick check, make sure everything's going well.
And that's what we would like as well. A lot of parents ask us, well, I'm coming in to see you every 6 weeks. Why do I need to go to the dentist? And something that's really important is that while you are coming to see us, and while Dr. Lasky and myself, we are dentists, we are not looking for cavities. We are not doing cleanings. We are doing adjustments on the braces, and that's pretty much it. So even though you're seeing us frequently, and we will alert you if we see anything obvious or outstanding, but it's still so important that even though you're seeing your orthodontist, you still have to go back and see the dentist every 6 months or maybe even more frequently to help with the cleanings.
Yeah.
And it might just mean that, they need to see more frequently to address some challenging areas, maybe not a full cleaning. And we'll give you an example. I know we're going to talk about retention shortly, but many patients who've had orthodontic treatment themselves, have a wire, a lingual retainer behind their bottom front teeth. That is also an area where plaque and calculus can build up because we have a salivary gland duct right there under the tongue. And so for patients whose saliva, is prone to producing calculus, they can get some buildup there. And we'll often, recommend that they go to have that professionally removed at their dentist's office, sometimes every 3 to 4 months. And we tell them, this is in your best interest. You don't need a full cleaning, but it'd be good to just have the areas where you're having a difficult time keeping it clean and just have that professionally removed.
Yeah, absolutely. One question I get a lot when I'm referring patients to you, parents like to talk about the different types of braces that are currently available. So, you know, people are very aware of the Train Track original style braces, and they've also changed quite dramatically, I think, with digital technology. But there's also Invisalign and clear options now,
Yes.
and even options on the inner surface of the teeth, maybe not
Yeah.
that child related. So what kind of options do you think are suitable for children, and when might you choose one over the other?
Great question. So, yes, there are many types of braces that are available to us. The traditional metal braces, actually all the braces that we use, they're called self-ligating. And I don't know if I have a larger model here, but traditionally, parents who've had braces before, you know, remember having those colored elastics around each brace.
Yeah.
And that was used to hold the wire into the brace. The braces that we use are self-ligating, which means we do not require that elastic to hold them in place. Each brace has a little metal door. And we open the door, we open all the doors, take out the wire, put in the new wire, close all the doors. That helps us. It's less friction on the braces, so the teeth actually move faster. But it also is much easier for the patient to keep their teeth clean because those little elastic donuts tend to trap food and plaque. Now, you probably have seen our patients with the elastomeric donuts. We can still put them on because a lot of kids want the colors. It's a fashion statement. And so we can use that as a motivator, you know, for good oral hygiene. We're happy to put those colors on, and patients can change them every month. But we do not need to use them with our style of braces. And so if a patient's having a hard time keeping them clean, we won't use them. But we really love this style of brace because it, you know, just makes our life easier in the practice, and it's easier for patients to keep them clean. The same thing with our clear ceramic braces, which we will give as an option to all patients, adults and adolescents alike. The ones we use, same, they have a little metal door that opens and closes. Again, from a hygiene perspective, it's amazing. But patients who've come to us for treatment again as an adult, you know, maybe they had treatment as a teen, said, you know, often they'll say, oh, I don't want the clear ones. I remember those stain. And it's actually not the braces that stain, it's the clear elastics that were used to hold the wire. That's what would stain. So these clear ceramic self-ligating braces that we use, again, do not stain, and they're a great option and really easy to keep clean. We do a lot of lingual braces, which are braces on the inside surface of the teeth. And it's become increasingly popular over the past couple of decades with increased technology. Lingual braces have been around for half a century, so they're nothing new. But previously, the old technology, treating people with braces on the inside surfaces, it is harder. You know, it's a little more labor intensive. We have a great system down pat because we do it so often. But using these lingual braces systems allows us to treat people in the same amount of time, whether they have braces on the inside surfaces or the outside. So the inside braces are custom made. They're one size fits every patient. And that helps us to counter, you know, the challenges of working on the inside surfaces and allows us to treat people with the same
option for an adult who really doesn't want anything visual, right? Because Invisalign you can still see. Correct.
The lingual braces, we have treated some adolescents with them, particularly musicians, where they're concerned about the braces inhibiting them playing certain instruments. We have had requests to use the lingual braces in that case. And Invisalign, which is clear, you know, the clear invisible braces, for us, they're not suitable for every patient. And so certain situations, particularly a deep overbite, a very deep overbite, where the top teeth the top teeth overlap the bottom teeth, we can, in certain bites and in patients with certain jaw structures, do more treatment effectively with braces. And so if they're really opposed to braces on the outside surfaces of the teeth, the lingual ones are suitable for for teens and adults alike. If a patient is a candidate for braces, they're a candidate to have them on the lingual or inside surfaces or the outside surfaces. Invisalign is an amazing product. We love it. It's been around for over 20 years, and the company is incredible. They spend millions each year improving their product. And we are very comfortable now treating teens with Invisalign. I don't think we would have said the same 5 years ago, just because.
Like with the new iPhone generations, with each new generation of Invisalign, are we on generation 7, I think now? 7, I think.
We're up to like 10 now.
Of Invisalign?
Or Invisalign.
For Invisalign. Oh.
Yeah, 7.
Yeah, G7, I think. Yeah.
Yeah. And the advancements have been spectacular. Yes.
And so they're always trying to find a way to improve their product. And in a teenager, in an adolescent that will wear them, they will work really well. And even in a teen with a deep overbite, they'll actually work better than an adult who's not growing with the same bite. The biggest issue is compliance. If they're not worn, they will not work. But, my daughter, who's, not too far away from starting orthodontic treatment, she's now coming to me saying, I want Invisalign. And I'm actually, considering it. It may be
her at home.
But she's had some challenges with oral hygiene. I bought her a water pick even without, she doesn't have any orthodontic appliances in her mouth now, but it's really helped improve her oral hygiene. And if she's willing to wear the appliance and be compliant with it, she will probably have an easier time with her oral hygiene during orthodontic treatment with Invisalign compared to braces. The way that we approach it is whether we're seeing a child, an adolescent, teenager, an adult, we like to tell them what their options are, what will work for them, what are the pros, what are the cons, what are the advantages, disadvantages, and let's make an educated decision together. We don't like to push one appliance because it may not be suitable for that patient.
Yeah.
There are a couple.
For adults who come to me to do Invisalign, so I don't treat children's orthodontics. I refer over to you guys. I usually treat adults who maybe have been through braces before, their bite is corrected, and they've had a small amount of relapse, like myself. But I always say you need to see an orthodontist for a second opinion. It's always important to see all options, because if you go to a general dentist who has a special interest in Invisalign, and they may do quite a significant amount of Invisalign, but they don't offer fixed braces. So you need to be able to see what different solutions there are.
Yes, and you want to make an educated decision. We feel that if we are pushing an appliance on someone and they make the wrong decision for their lifestyle, it's not going to be a win-win situation. So we want to educate patients and let's make an informed decision together. There are situations, I'd just like to bring up, an open bite, for example. So the opposite situation, where a patient, their front teeth do not contact. Previously, we have a lot of patients coming in who are told this can only be addressed with surgery, jaw surgery. And while that is an option, we are getting some amazing results with Invisalign for that particular bite. So that's one bite where Invisalign may be more effective than braces. Whereas a deep bite, as we talked about before, where the top overlap the bottom significantly and maybe causing wear or chipping of the teeth, oftentimes braces, will be more effective. But as well, we are willing to work with the patient, their requests, their lifestyle. We'll mix and match. We treat many patients where we do Invisalign on the top and braces on the bottom.
Very cool.
Use the braces to achieve what we need to do with the braces and then finish with Invisalign. And oftentimes, because patients don't show their bottom teeth when they smile or when they talk, this is something that adults are very accepting of.
And Stacey, I saw something pretty cool behind you there. I know that you guys have some digital technology at the office. So, when I got braces, there were the gooey impressions, lots of gunk in my mouth, and I remember that gag. What have you got behind you?
So this is one of our best friends at the office. It's an iTero scanner. It's a digital scanner. And instead of having those goopy molds that we're all used to when we were younger, this it's a digital camera, and it's a handheld camera. It goes into the patient's mouth, takes a 3D image of the patient's teeth. There's no radiation, so you don't have to worry about that. It's all digital. And we get really accurate scans of patients' teeth, so it ensures that all of our appliances, our expanders, our Invisalign, our braces, everything fits the patients really accurately. And we love it. Patients love it. It's very cool, and it's very interesting. You can also see, like, from before to the end, you can superimpose. You can see all the changes that happened. It's quite amazing. We should have turned it on.
Some of my
It's really great.
We also have one, and we use it to, for Invisalign cases, but we also use it for prevention. So those patients that have tooth wear, gum recession, we like to monitor them, scan them every year to 18 months, see changes. And same for night guard impressions. Like, the accuracy, the fit of a night guard, they're almost too tight. They're too good.
Exactly. We've had also parents come in and request sports mouth guards for hockey. So if your kid is a gagger, or the national sport check mouth guard isn't really fitting well, we make mouth guards off of these. Right. Patients love it. It's very accurate, and our appliances fit so much better, and we get better results because of using a digital scanner versus the goopy mold.
Very cool.
And we use it for monitoring as well. Patients will come back wondering if a tooth is moved. Sometimes they'll come to us and, they're contemplating treatment to remove one tooth that has gone astray. And sometimes they just want to monitor it. They'll come back years later and we can compare. It's honestly been amazing, though, during this lockdown, because the scans are stored, forever. We've been able to help out many patients by replacing their retainers and having them pick them up curbside, as opposed to letting their teeth move and not being able to help them because it's, not safe to have them in the practice. I cannot imagine practicing without it. It's amazing. We've had our scanners now for 7 years. So we've seen a couple of generations of the scanners. It's absolutely amazing.
Yeah. We've had them for a couple of years too. It's just a no-brainer, just so accurate, and patients just love it. It's so comfortable compared to what they expected from the traditional molds.
Yeah.
So one of the things that a mom sent me was a young infant with an underbite. So where her lower jaw is kind of sticking out compared to her upper jaw, like that kind of thing. And they were wondering, we were chatting about this before, if you start to see things like that in your very young infant, when do you get concerned? And is there anything you should check on early before before that later stage at 7 or 8 where you're going for orthodontic assessment? If you start to notice something happening to their jaw early, is there anything you should do?
Yes, something that's tied to the airway is ties of the tongue and the lips. And sometimes seeing a young infant or child that's bringing their jaw forward, it can be a sign that they're having some difficulty getting air into their airway. And some kids will manually and subconsciously push their jaw forward to help get air in. And when we see that, first thing we like to do is ask the parents, or when we get that question, is just also get more information. Was there any issues with the child nursing, or latching, feeding? Because all of those together may be a sign that the patient has a tongue and or lip tie. And one thing that can be done is just to have an assessment for that. And sometimes the tongue or lip tie can be snipped, and can be a huge lifesaver for these patients and for the parents. I know you're going to be speaking with Dr. Lori Goldenberg of Smile Squad next week, and Dr. Goldenberg and I have talked extensively about this because we're both very interested in it. She does assessments of young infants and child, and she's best suited for that. So she's right down the street. It's very easy to go and see her, and she would gladly do it. And she's also very conservative. She won't recommend a snip of the tongue or lip tie unless she's absolutely certain. But after researching this over the past couple of years, even one of our hygienists, who's currently on maternity leave, with her second child, she's had both children have a tongue tie addressed, and noticed a huge change in how her children nursed after that. So if any moms out there are having concerns about nursing and latching, and or seeing the child push the mandible forward, it may just be a habit, but it doesn't hurt to get an assessment, because something can be done even at a young age. And if it is necessary and it is addressed at that age, it can help the patient down the road, whereby they might come to us at 7 and 8, and things already could have improved significantly than had it not been addressed.
And the last big topic we wanted to talk about is all about retainers. So retainers are what you wear after you finish braces, and or don't wear, might be the case. And what are they? Why are they important? How long should they be worn?
Yes. Okay. So first, retention is so important because the teeth are susceptible to moving at any stage of life, at any age. And this is something that we talk about from the very first meeting. We literally talk about it at every meeting with the patient and parent, because we want to get the message ingrained in their mind. And we cannot tell you the number of people that come in that their jaws drop when we say this is a lifetime commitment. This is, yes, a 2-year treatment, a little more, a little less of orthodontic visits, but retention is a lifetime commitment. And if they've invested time and money into their orthodontic treatment, we don't want it to relapse. If teeth stayed where we put them, our job would be very easy. Unfortunately, that's not the case.
That's the back, not from you guys, but I mean, that's why a lot of adults end up back in a general dental office looking for Invisalign. 9 out of 10 of those patients for me are patients that had braces and, didn't wear their retainers, or retainers broke and they never got them replaced.
Yes. And part of that's the messaging. I mean, I remember my father saying to me and to other patients, oh, when you get married, you can stop the retainers, or when you're in your 20s or 30, he would just refer to a certain point in life that you would need it. We now know that's not true. You need retainers for life, and that's what we practice, and that's what we preach. And, it all depends on the patient. Oftentimes teeth can relapse because of pressure from the tongue, and again, that can be an airway issue. Sometimes teeth will stay in place until the patient stops growing, or until they're an adult. And when they're not growing, if they are grinding their teeth at night, the teeth can withstand the pressure for a certain amount of time, but eventually they will start moving in response to that. So retention really is a lifetime, commitment. And oftentimes we'll see parents of patients, whose retainers broke years ago and their teeth fortunately haven't moved. We're always willing to help them. But for our patients and the parents, basically we're educating them on 2 types of retainers. We have fixed and removable retainers. So the fixed retainers is this little wire that is glued to the teeth. Every patient has room for this on the bottom front teeth. Most patients, especially if we've done a good job at reducing their overbite, have room for one on the top as well. And we recommend this for every patient. We also have removable retainers. This is called a Holly retainer. It has metal components often on the outside and then in between the teeth, with a plastic component that goes in the roof of the mouth. We do these for a lot of patients after having the expanders done to hold the width.
Yeah.
But for most of the patients after braces, we recommend a clear S6 type, or Invisalign has their brand called the Vera retainers. And so oftentimes we'll work with the patients to figure out what's the best for them. but we recommend both fixed and removable retainers for all patients. Sometimes
your plastic ones, Brian, how long do they last? There must be a bit of flexibility.
yes, unlike Invisalign, which is designed to only last a few weeks, these are thicker, and on average they last about a year. If a patient is grinding their teeth, they may last less. And then we have some patients that take really good care of them, and they can last 2 to 3 years each. But it does vary by patient. The material does come in different thicknesses. So if a patient is having difficulty with our standard thickness, we might make something that's a little bit thicker for them. And but this is very important to wear. The wires as well, you know, we tell patients that they often, if they're well taken care of, can last upwards of 10 years. Some patients can keep them longer. My wire has been on, you know, I think for 28 years. They can come unglued or detached from a tooth, and it's very easy for us to reattach it. And there are some patients out there we know that have messaged us that they're in need of us helping them with that, and we hope to get to them very, very soon. But that's a great example of why we need both. Those patients that have the clear retainer are able to wear that now to keep their teeth, to prevent them from moving.
Yeah.
We recommend the clear retainer worn full-time, so day and night for 1 year after treatment, and then after that, nightly is fine. And some patients are even able to go down to 2 or 3 nights per week, but we recommend 2 to 3 nights per week wear indefinitely. And, you know, again, we talk with patients about their specific bite and why the retainers will be helpful. If patients presented initially, you know, with spaces between their teeth or severely turned teeth, you know, both of these retainers are going to be important to help prevent relapse. Spacing could be an indication of pressure from the tongue had pushed the teeth forward. And so we are unable to change the shape of the tongue. Oftentimes we may refer patients for tongue thrust therapy with a speech and language pathologist or speech therapist that's trained in myofunctional therapy, which can help. But oftentimes the tongue, which is one of the strongest muscles in our body, and we swallow 2,000 times a day, the tongue wants to push those teeth back to where they came from. And so again, the wire and the clear retainer is imperative. And oftentimes one is not enough.
Yeah.
There's benefits, many benefits, as we've talked about, to having both. Do you have anything you want to add?
I just wanted to add, if you do have a wire in your mouth and it is broken, don't wait. As soon as it breaks, give us a call. I mean, right now we're sort of closed.
Quickly.
But I hear all the time, I ask, when did your wire break? And they say, oh, I don't know, a few months ago. Don't wait. Your teeth can move, and then the only way to get your teeth back into position is with braces or Invisalign again, orthodontic treatment. So as soon as you notice that your wire might be loose, call an orthodontic office, try and get in, try and get it repaired. Yeah.
So I will say, guys, I think we've got probably a minute left till it just automatically cuts us off.
Mm-hmm.
And so I just wanted to say thank you to both of you so much. We were with Orthosmiles today with Dr. Lasky and Dr. Kirschenblatt.
Thank you.
So much valuable information. This will be available for 24 hours. So please look back and pick up on anything that you may have missed. Of course, feel free to email or to message both of us. Be sure to follow Orthosmiles Toronto. And next week, next Monday, I'm going live at 5 o'clock on Monday with Smile Squad Kids. With Dr. Laurie Goldenberg answering all of your pediatric dentistry questions. And then on Thursday, I'm also going live with Dr. Stefania Palmari, who's an infant nutritionist, and she also works with children who are having motor or sensory issues related to nutrition. So I hope you join me next week. Thank you to everybody for joining us today. Thank you to you guys so much, both for today and for just excellent care of my patients to this point.
Thank you for having us. It's a pleasure working with you, and stay healthy and stay safe. And let's do this again.
Definitely.
Once hopefully things are back to normal.
Person.
Yeah, we'll do it again when we don't have to socially distance with each other. I can't wait for that day.
Talk to you soon. All the best.
Take care. Bye-bye.